we go ahead and get started? That's I think some pretty good cases in here for you guys this morning.
Sure, Dr. Cockerell, I can take this one. This is Usman from Baylor. Good morning.
Morning.
So it looks like we are looking at a punch. From this power, I would favor an inflammatory process over a neoplastic one.
Good.
Looking from the top, the epidermis looks a little bit irregular, maybe acanthotic in a couple of areas, but otherwise, maybe not too much going on there. Right below, I do see some papillary dermal edema. And then below that, in more of the reticular dermis, I see both superficial and deep perivascular inflammation going on, and some of it extends, it looks like, to the fat as well, perhaps.
Yeah, no, I think you're right. And you can sort of see, can you tell the difference between the color of these cells and the color of these cells up here at low power?
Yes, sir.
Yeah, I mean, that's, again, I'm not going to ask you to really make a definitive diagnosis at this power, but these look to me like they're probably going to be, at least some of them are going to be lymphocytes because they're really dark, but there are also these inflammatory cells up here that definitely don't look as dark. So we're not sure what they are, but you can say, you know, these almost, we're going to bet they're going to be lymphocytes. These may be something else. And so what's the most striking thing that you see at low power about this biopsy? What is your eye immediately drawn to here?
I guess I would say the edema and also the clusters of inflammation.
This is the thing that hits you right away. And that's important because there's a relatively small, see, the idea behind looking at things at low power is to make a relatively short differential and then to confirm it when you go to high magnification. So if you know maybe 6 or 7 things that can give you massive papillary dermal edema like this with relatively limited epidermal involvement, you can kind of get the differential diagnosis down pretty quickly. And then you say, okay, well, when I go to high power, if it's this disease, I'm going to be looking for this. If it's this disease, I'm going to be looking for that. And so that's the value of pattern recognition. You basically start off at low power, and like a zoom lens, you kind of gradually go in and hone in, and then you can make a specific diagnosis. So what are some things that cause massive papillary dermal edema?
Well, a couple of things could be like an arthropod bite.
Good. Yes, a bullous bug bite reaction. That's a very good one. And if you take patients with this papillary dermal edema pattern like this, it gives you an edematous papular plaque. So in other words, it almost looks like it's sort of a balloon that's ready to burst. It's sort of, we used to talk about fixing to vesiculate. Dr. Eichhorn used to say here, he's a dermatologist attending who retired a few years ago, was a really good teacher, and that's what he used to say. And so I think that's true. It's a good way to remember that. So that's one of the things you can see is a bullous bug bite reaction. If you ever see a patient with a bullous bug bite reaction, after that edema sort of, if it does vesiculate in a couple of days, and you get it like some collaretive epithelium, some crust, that kind of thing. But when you get it really early, it still has a normal basket with cornified layer over it. Hadn't even really had a chance to make any spongiosis or anything like that. So that's one entity. What are a couple of others that can do it?
A couple of others, I think maybe sweets can also give you some papillary dermal edema. I know you see all the sheets in these quiz.
Second one to think about, that's definitely one to put up there. So sweets, bullous bug bite, those should instantly kind of come to mind. What's another one that's classic papillary dermal edema?
Could you see this with, if you had a bullous ACD, for example? I know you'd see more spongiosis and epidermal.
Yes, but you're right. You can get papillary dermal edema in bullous allergic contact dermatitis. So simply that, like, for example, poison ivy, where they get a really super acute hyperimmune reaction to something, they can get prominent papillary dermal edema in that. They usually do get spongiosis with that also. So that would, that'd be a little less likely for this specific case. But yes, that is something that you would think about with papillary dermal edema.
Okay.
Two others. There's not that's the nice thing about that reaction pattern is there's not a ton of them. So that's the nice thing about it.
And then I'll think of PMLE as well.
PMLE is the other classic one. Those are probably the 4 biggies. And then you know, the parapox virus infections, you can get some papillary dermal edema with some of those. Massive stasis change, you know, where you get like lots of edema of somebody's leg, they can get papillary dermal edema with that also and get blisters. So when you see so-called edema blisters, they can give you that. Bullous dermatophyte infections also, just like allergic contact dermatitis, give you massive papillary dermal edema. That's about it. So that's pretty good if you can kind of get a short differential and you can look at it. So if we're going to distinguish between those, we're going to probably rule out the contact and the bullous dermatophyte because there's really nothing going on in the epidermis. So we're going to think about some of the others. And then we're going to higher magnification, start looking at the cells. You can see that there's some leukocyte aplasia here, there's some lymphocytes, but there's also some neutrophils in some of these areas here.
Yes, sir.
So this was a case, I think the clinical was pretty good for sweets here. And it also has this basophilia of the collagen we talked about. So that's kind of a sign of neutrophils being in this infiltrate. This was a little funny because it does have some lymphocytes also. And most really classic cases of sweets will give you a dense, diffuse infiltrate with tons of polys. So this one's a little funny, I would say. The other one I would put in the differential too that isn't, that we didn't mention is pernio. And that occurs on volar skin. I mean, that could also look somewhat like this also. So, you know, even though this is labeled as sweets, if you thought it was maybe possibly a bullous pernio with papillary dermal edema causing the vesicle, that would be fine. If you thought of PMLE here, I'd give you credit for that also, because this is a little funny for classic sweets. But I think the history in this case is really what kind of made the diagnosis. And you can see there are some other cells and lymphocytes. But that's the main thing on this case to remember. So it's not always about getting the right answer. It's really getting an approach. So when the board throws something at you, then you can, you know, get it right. And they're not going to show you a case like this that turns out to be sweets that's a little atypical. They're going to show you a classic case of sweets. So if this was sweets, it would be neutrophil, a sea of polys. Be so total polys here, nodular and diffuse with papillary dermal edema. They wouldn't show you something that the differential might be PMLE histologically, and pathologists argue about it. They're going to show you something that there's no argument about. So that's the main teaching point here is the papillary dermal edema differential. And just remembering the various other things that you use on top of that to give you a definitive diagnosis. So if I was looking at this right now, I'm not sure I'd call this sweets. I would say, you know, I'm not sure I believe the diagnosis. I think it might be pernio because it's a near volar skin. There's no follicles, you know, and we see a lot of this in patients with COVID. So good.
That's right. Okay. Okay. Well, thank you so much, Dr. Cockerell.
You're welcome. Any questions about that one?
If we were leaning more towards PMLE, would we be looking for more just lymphocytes without any neutrophil involvement?
Yes, you would absolutely. That's usually more of a tight lymphocytic infiltrate around the blood vessel, so you don't usually get much of an interstitial pattern. And even though there are some polys here, which I guess is why we ultimately sort of called it sort of maybe an atypical sweets. Yeah, you generally like to see just around the blood vessels with the papillary dermal edema in that condition. So that's exactly right.
Okay. Okay. Very interesting. Thank you.
Okay. Another one here. This one's really an interesting case.
Good morning, Dr. Cockerell. This is Leah. I'm from Baylor.
Okay, great. You know, some of these the patterns are really beautiful here on some of these. You know, sometimes the low power is the most powerful power. So,
low power is high power.
Well, that's what the good old Dr. Ackerman used to say, that low power diagnosis, high power mind.
I like that. Okay.
There's some truth to that in many ways.
So here it looks like we have perhaps a deep shave, or maybe even, I don't know, an excision.
Yeah, it could be like a saucerization. You know, sometimes people do kind of weird punches. I suspect this might be a deep saucerization. A lot of guys, unfortunately, because it costs a little bit more and takes a little more time to put a stitch in, and they don't pay you for your suture and this, that, and the other. They used to pay for a suture tray years and years ago when I was a resident. I don't think they pay for any of that stuff now. They just lump it all in there, and they always keep trying to figure out ways to pay us less. So that's why we're getting more shave biopsies of inflammatory diseases, because it's a lot cheaper just to use a derma blade and just do a deep sauce biopsy. We really wish we could have a punch, but
yeah, it might have been nice to see the fascia. We'll go down a little bit deeper for this.
yeah,
So
fat here.
okay, so in terms of kind of our process, we are seeing kind of components of both an inflammatory and perhaps a neoplastic process. It's a little bit hard to say from here because we see this large pink thing in the dermis.
Yeah, good. We're seeing something pink in there. And then, what about the epidermis?
The epidermis looks very atrophic. I'm noticing some hyperkeratosis as well.
And notice this pattern over here. What about this epidermis?
It looks relatively normal. I mean, the reedy rates are preserved.
Excellent. Normal. Loss of epidermal reedy. And then what's going on right here?
So I see some like severe atrophy of the epidermis, and then also some liquefactive degeneration at the bottom.
Yes, exactly. You've got some, I think there's, that's correct. There's some vacuolar alteration here. There's thinning in the epidermis. There's overlying perikeratosis. There's pink discoloration in the epidermis, which means that it's dead. So it's not normal. And then you go over here and it kind of comes back to normal. So what does that sort of tell you?
Well, there's some sort of inflammatory process that's localized here, and it feels like it starts and stops.
Yeah, exactly. And then you see over here, here's the inflammation around this blood vessel here. Look over here, there's also some around this blood vessel. And what is this material?
That looks like mucin.
Good, excellent. That bluish gray granular fibrillar material, that's mucin, and it's not solar elastosis. So there's mucin, there's perivascular lymphocytic inflammation. If we went deeper, we'd probably see some of that. What about these blood vessels here?
So
Is that a normal vessel wall here?
Yeah, it looks like the vessel wall is kind of hyalinized.
Yes, it's kind of hyalinized. And then what about the collagen in the center part of it here?
So we see very thickened collagen bundles, and then at the top it looks very homogeneous.
Good. And so when you see homogenized collagen with a diminished number of fibroblasts, what does that tell you? What's that pathologic process known as?
With diminished,
decreased fibroblast, homogenization of the collagen bundles.
Are you looking for diagnosis or a?
This what's the histologic reaction pattern called when you see that?
Sclerosis.
Good, sclerosis. Excellent. So sclerosis, that's exactly what that is. So we've got a sclerotic collagen, focally sclerotic collagen. Normal here, normal epidermis here, normal epidermis here, dead epidermis here, almost a wedge shape here. There's no real adnexal structures inside this area to look at because they've probably been destroyed thick, and they went away and they got replaced by this focal wedge-shaped sclerotic collagen here. So how do you put all this together? And there's
at the top of my differential was lichen sclerosis, just given all these features.
Okay, now is lichen sclerosis usually just focal like that? And does it go down into the deep reticular dermis?
I would not have expected that because all of the lichen
sclerosis. It does not do that. Exactly. So lichen sclerosis is confined to the papillary dermis. When it gets into the reticular dermis, and we say, well, it's morphia with features of LSNA. And by the way, we didn't mention this in our papillodermal edema differential, but lichen sclerosis can give you papillodermal edema as well. You can actually get blisters in bullous LSNA. So that's another thing to throw in that differential. But clearly it's not that because it goes all the way down into the mid-reticular dermis. And you don't usually see mucin with LSNA. This is a tough diagnosis. I'll just tell you that. You've probably never seen a case of this yet. You've heard of it. You've read about it. but you haven't seen it yet. So now you're getting an experiential learning here. So this is great because you're going to remember this probably for the rest of your life. That's good. But you notice the pattern here. So it's a wedge-shaped sclerotic collagen with thinning of the epidermis, and really it's an infarct. An infarct where everything turned into sclerotic, dead, degenerated collagen that became sclerotic after that with mucin around blood vessels and perivascular lymphocytic infiltrate around the blood vessels. And if we had deep blood vessels, they would be involved also. Any ideas about the differential, about what this might be?
So I also thought about morphia. I think there's Dego's
Morphia's not a bad
disease.
idea. Morphia's not a bad idea, but we have to sort of look at the rest of the facts here. Does it make sense? Do we get this kind of change overlying morphia?
No, and that's the
No, we
reason.
don't get dead epidermis overlying morphia, almost never. I mean, usually the epidermis is normal. It may be thin, but it's not that. Do you get mucin in morphia?
No, not typically.
No. So there's some features that, yeah, this you see in morphia, but you don't see these other things. So we say, well, and it's also so focal. Morphia is never focal. It's, this broad diffuse patterns. It's slide to side, top to bottom, square biopsies, right? So we don't see that. We see more of kind of what looks like an infarct in a way that's turned into. And you may not know what this is, and that's okay. That's perfectly fine, because you will know in a minute, and then you'll never forget it. Does anybody know what this might be? Well, what if I told you this was a, say, 30-year-old woman, and she had a history of multiple GI bleeds over the last several years and had lancinating GI pain, and came into you with these papules that were porcelain white on her skin. And some of them had eroded at some point in time. And you took a biopsy and this is what it looked like. And she had a positive A&A.
I think that sounds like Dego's disease.
Dego's disease. That's exactly what this is. Malignant atrophic papulosis. That's the name of it. It's called malignant because of the malignant GI effects that they get. And what this is one of the few examples of possibly a true lymphocytic vasculitis. We don't really see too many cases of real, honest to goodness, lymphocytic vascular compromise. And usually it's just perivascular lymphocytic infiltrate, like in a PMLE case or perneal, like we just probably saw a minute ago. But this is a disease where you do see degeneration of blood vessels and thrombosis of the lumen, often with mucinous degeneration of the blood vessels and a lymphocytic infiltrate around the blood vessels. So this is Dego's disease. And basically what you're seeing here is an infarct. So this is what the porcelain white lesion looks like when you biopsy it. And notice that it's got this wedge-shaped morphology to it. Can you kind of appreciate that a little bit here? It's basically, and you can, anytime you get an infarct in the skin, it tends to be wedge-shaped because you get the blood vessel dies at the bottom, or it gets plugged off, or the ischemia happens at the bottom, and then the necrosis kind of spreads north like that. So it looks wedge-shaped at the top. You have less blood up here when you thrombose the blood vessels down here. So you still have a little bit of blood vessels that's going to nurture this stuff, but it doesn't nourish the stuff up here. So that's why you get a wedge-shaped pattern. Anytime you get an infarct like that, it's almost always sort of wedge-shaped. So this is what Dego's looks like. And Dego's is thought, we actually wrote a paper on this a number of years ago, to be a variant of lupus. It's probably not exactly lupus, just like we have all these new subtypes of dermatomyositis. Maybe this is maybe Dego's is a subtype of dermatomyositis in a way. Who knows? It may be kind of an MDA5 dermatomyositis-like process or something. And the more we kind of learn about the subtypes of these connective tissue diseases, we're probably going to say, well, it's not classic lupus, but a lot of these people do have positive A&As. And our postulate was maybe it was a variant of lupus, and maybe it is. But look at this blood vessel. I mean, it's hyalinized, and when you get that kind of change, it results in loss of, the blood can't get to the smaller capillaries and everything, and they sort of just, you get this ischemic necrosis. And that same thing happens in the GI tract. So this is Dego's. So this is what it looks like. So when you get it looks like this. So this is a really good example of it. Any questions about that?
No, that was an interesting case. Thank you.
Okay, so we got some really good stuff for you guys this morning here.
Hey, Dr. Cockerell, this is Christina from Baylor. I can take this one.
Okay.
So looks like we have a punch here. I can't see the exact location, but doesn't look like we're on the scalp or a large hair bearing area. And the thing that kind of hits me from high power is that I see a lot of kind of like fat cells higher up than I would expect. So
You know,
I
we
put this
see
on.
that a lot of times, and I'm not sure anyone's really satisfactorily explained why that happens. I mean, a lot of people talk about it as being fatty metaplasia and things like that, and it happens a lot. We see that, like, say, in the middle of this, beneath the shave biopsy of seborrheic keratosis a lot of times, you know, and I don't know why it happens, but it's kind of a normal variant of normal in a way. It's not really pathologic.
Okay, good. And then I don't see like a lot of inflammatory cells. I think I would call this more of a neoplastic
Yeah, you know, and we
lesion.
sort of simplify things and say the two major categories are inflammatory and neoplastic. There's some other things that actually sort of are collateral to that, if you will, like pigmentary disorders. You know, is vitiligo really inflammatory? You know, probably not. Or are deposition diseases like amyloid, are they really inflammatory? No, not really. You know, things like that. And or malformations, are they really neoplasms? So if somebody's got a genetic disorder and maybe they don't make enough hair follicles or something like that, is that really inflammatory neoplastic? So really not. So sometimes we have things that don't fall neatly into the two categories. So this may be something like that, because I agree with you. This doesn't look inflammatory or neoplastic. When you get stuff like that, you sort of say, well, you know, if it's inflammatory, it's really super sparse, perivascular. There's almost nothing. It doesn't look like a neoplasm, or unless it's maybe a weird lipoma or some kind of fatty hamartoma. And then another thing I always do is I start looking to see if there's any abnormalities of the collagen bundles or something like that. You know, like maybe it's a collagenoma or, you know, something along those lines. Look to see if there's any pigment that's deposited. And did you notice anything about anything going on down here? And this is subtle. I mean, you'd have to sort of really look, but what's this? It looks almost refractile. It is refractile, actually, in purple. What gives you that?
Is it like a foreign body?
It's not foreign body. But recognize that as calcium.
Okay.
Whenever you see something that looks like a little crystal and it's purple like this, you know, that's what calcium looks like in the skin.
Okay.
Calcification in the skin. And notice where the calcification is occurring.
Kind of, around the vessels?
Well, some of these are maybe vessels, but they're also fibers. You see this up here? Subtle, but can you see that little fiber right there that's thickened? And it's normally you hardly see these fibers in normal skin. Here's some more over here. These are elastic fibers, calcified, actually. And sometimes this is a prominent amount of calcification. They actually form little crystals of calcification. The classic calcification that we see in this entity, it kind of looks like steel wool, but this looks a little bit different. So what's the diagnosis of the disease you get when you get calcification of elastic fibers?
I think that's the pseudoxanthoma elasticum.
Good, that's pseudoxanthoma elasticum. Now this case is a little different because this is kind of like that first sweets case. It didn't look perfect for sweets, but it's got the calcified elastic fibers here. We thought this was probably sort of a pseudoxanthoma elasticum-like process. And you can get PXE in patients that, say, are pregnant and they have C-sections or whatever, and you biopsy their umbilical area. There's like a plaque there. It's a localized PXE-like reaction, and they can get a secondary dystrophic calcification of their elastic fibers. And that's really most likely what we have going on here. But the main teaching point here is to recognize that these are elastic fibers, markedly thickened, and they also have this calcification of them. So we call this like a PXE like reaction, not just a classic PXE. The classic PXE really got the steel wool. And I don't know if you guys know what steel wool is, but if you haven't, go to the hardware store and go to Home Depot and look at steel wool they used to kind of scrape paint off or something like that. And that's what you see with the elastic fibers, that sort of fine, kind of tufted sort of grayish material. That's what you see in classic pseudoxanthoma elasticum. This is just a little bit different. You usually don't see these little globules of calcium, but sometimes you can, especially in the PXE like reaction.
Okay.
So that's kind of an interesting case too. I don't think they'll show you this on the boards, but I did just want you guys to appreciate the concept of calcification, and then the elastic fibers being calcified, and they're pretty much down in the deep dermis. And PXE is kind of all over the place. So this is some kind of traumatic, post-traumatic PXE like process, most likely would be my bet.
Okay. Thanks, Dr. Cockerell.
You're welcome.
Hello, I can go next.
Okay.
This is Jamal from UT Houston. It looks like we have maybe a punch, although I don't really see an epidermis. So it could have maybe been excised or something along those lines.
Yeah, I'm not sure what the proper orientation is here either, actually. It may go like this.
It's sort of hard to tell because you can see the fat sort of towards the bottom, but only very little.
Bottom, it's either bottom here or bottom that way. It might be like a 6 millimeter punch. And then it was just, you're right, there's no epidermis. It's probably ulcerated.
But just looking at it, it's like, I think it's more inflammatory.
Good.
And it's like a diffuse, inflammatory process.
Exactly. This is nodular and diffuse pattern. Exactly. Everything's involved, top to bottom, side to side. And, I presume it's ulcerated. It's possible that could be like a lab artifact that it got sheared away, but
it's a pretty clean.
There is no epidermis here. Exactly. What kind of cells are these?
Some of them are a little darker, but a lot of them are like a little lighter. So I was thinking more like histiocytes.
Good. Lots of histiocytes here.
Yeah, and then whenever I got closer, they seemed a little bit foamy in places. It's like maybe foamy histiocytes.
Okay. Okay, so let's take a look at that. Foamy histiocytes. Good. So what's your differential diagnosis when you see something like this? It's got a very dense diffuse infiltrate and it's got foamy histiocytes. What is your differential diagnosis of histiocytes with abundant lipid in their cytoplasm?
So for lipids, you can think of like a xanthoma.
Okay. Any particular type of xanthoma? Like what type of xanthoma would this one be if this were going to be a xanthoma here?
Maybe like an eruptive or?
Well, the eruptive ones, interestingly enough, of course, those are mostly triglycerides, and you get a lot of extracellular lipid in that. There are going to be intact foamy histiocytes as well, but because the lipid levels are so high and they get so high so quick, you get a lot of they sort of pop, if you will. They get so filled up and chock full of the triglyceride that they actually then rupture, and you get extracellular lipid that looks bluish gray, and it actually looks like mucin, and it can actually simulate granuloma annulare histologically. I've seen that diagnosis missed because it looks like GA because the extracellular lipid looks bluish gray like mucin, and it's not mucin. So that probably wouldn't be the most common form for this specific lesion, but you're right, you can get foamy histiocytes in eruptive xanthoma. What xanthoma would look like this specific lesion, like this area right here, for example?
Would it be like a tuberous?
Yeah, probably a tuberous xanthoma. If you ever see a biopsy of one of those, it looks like these big, large nodular aggregations of these foamy histiocytes like this. So yeah, that would be more likely a tuberous xanthoma. What else can give you some lipid in the cytoplasm of histiocytes?
Would you get like an AFX Could you get it?
You can get foamy histiocytes in an AFX, yeah. You know, in some of those neoplasms, you absolutely can get that on occasion.
Maybe like JXG.
Yeah, you know, you see the Teuton giant cells. I don't know if that stuff is really foam, but you do get kind of a clear cytoplasm in those for sure. And then, you know, like say foreign material, let's say somebody injects paraffin or something like that in their skin to try to increase their girth or size or whatever they're trying to do there. Those histiocytes engulf those lipid, that foreign material, and they can have a foamy cytoplasm also. You can get droplets inside the cytoplasm in a silicone granuloma. It's not really lipid, but it can kind of look sort of like foam, if you will. So yeah, it's just good to have a differential diagnosis. And then of course you can get other things that really aren't histiocytes that have foam in their, or lipid in their cytoplasm, like sebaceous cells. So you want to make sure that you didn't confuse these with those. And those, you know, cells can kind of look sort of like that if they're sebaceous. It's got the crenated nucleus with the little gossamer strands. So whenever you get lipid in a cell, they can kind of look like a sebaceous cell. Clearly this isn't sebaceous here, but that's just something to remember. Anything about so what did you think was going on in this specific case?
Well, I see like these little round openings that have like some material inside of them. And then there was like a stain after this.
Stain helps, doesn't it?
Which revealed, I thought these were maybe globi.
Globi. So tell me what a globus is.
It's sort of like a collection that within the dermis that has like the organisms kind of packed inside of them.
Yeah, it basically, and again, a globus basically means kind of a ball, if you will. It means like a nodule or something. And they used to call those, you know, the old wooden sculptures of the Native American chief in the cigar store holding the, you know, the little group of cigars together. They would call those a globus, a globi of cigars, if you will. And so if you look inside the cytoplasm of these, you can imagine all of those little gram-negative rods kind of clumped together. Picture somebody holding those together, and they have tons of lipid because they're waxy, they're mycobacterial. And the lipid is due to the waxy capsule of the mycobacteria. And that's what that's what the globi are. They're the little sort of ghosts, if you will, of the mycobacterial leprosy that are sitting inside these cells here. So this is an example of Lepromatous Hansen's disease. And if you go to this special stain, there you can see all the gazillions and millions of organisms that are sitting in here. A lot of them are, and a lot of this is just lipid that's out here. You don't actually see a lot of the intact organisms. Some areas you do. It's kind of hard to see with this scan image, but all of this is positive here. So this is a person that had, and here's another area. Maybe they're better over here. You can kind of see, you can see the rod-like structures here. If you look carefully,
yeah,
these are little globi right here. And what are these cells called?
Like the acid-fast bacilli.
Well, they're acid-fast bacilli. They're fight positive bacilli, because if you actually use a regular Zeal-Nielsen stain, they don't stain as strongly because that's got a stronger decolorant in it. If you use a fight stain, it doesn't decolorize the AFB as much because the mycobacterium leprae are a little bit more weakly acid-fast than mycobacterium tuberculosis. So we never use those stains really to distinguish the two anymore today. But in the old days, they would say that the Zeal-Nielsen stain would stain a regular MTB, and fight stain would stain Hansen's organisms. Probably get some staining with both, but all MTB will stain with fight, but not all Hansen's will stain with Zeal-Nielsen. So that's kind of just a little thing to remember. But there's a special name for these cells. It's named after a very famous professor, that pathologist that looked at these cells years ago with an old, mononuclear eyeglass monocular microscope with probably a candle or something like that they were using to look at make the light. Anybody know who the professor was? Virchow. So if you see the name Virchow, that's not pronounced Virchow, it's pronounced Virchow. And he was a famous pathologist back in the 1800s. I think he actually looked at one of the czars and helped him when he had tongue cancer or something like that. There's a Netflix movie called Charité, Charite, that talks about a charity hospital in Paris where he worked for a while, and he's in that movie, and so when on the Netflix series. So if you want to look at some historical thing, you can learn about Professor Virchow. But this is diffuse multibacillary lepromatous Hansen's disease. So this is what the Virchow cells, the globi, look like. Did everybody get this one? Especially with the special stain?
Yes.
Good. And that's fair. I mean, they could give you that on the board. So that's something you could get very, very easily. This is also something that you're probably going to get. So you may as well just, certain things you just may as well go ahead and surrender to the almost fact that you're going to be asked this on the board examination somewhere, someplace for sure.
Hey, Dr. Cockerell, this is Edgar at Baylor. I can take this one.
Good.
So it looks here like, I don't know if this is necessarily a biopsy or an excision. It looks, I wouldn't say this is an inflammatory or a neoplastic process. I am seeing a lot of full thickness separation of the epidermis from the dermis.
So you don't think it's inflammatory necessarily when that happens?
Well, I think there is some level of inflammation, not a very robust inflammatory process, but there is some perivascular inflammation, I would say.
Good. That's the key. So yeah, so this patient is superficial perivascular dermatitis. So it is inflammatory, but yes, it's just got, at least at this power, we see just mainly superficial perivascular inflammation here. And then you said something, you said there's a separation here.
Yeah, I think there's a full thickness separation of the epidermis from the dermis. A lot of blood I see as well from this level.
Good. Now, how can you tell the difference between a histologic artifact? Sometimes we'll get like say a previous excision of a basal cell, and there's obviously a scar from the basal cell, prior biopsy, maybe there's even no residual cancer left. And then you see the epidermis is separated from the scar. And it's just something that happens because there's not a normal adhesion between the epidermis and the scar anymore. It's trying to reepithelialize, and it's basically just a histologic artifact. If you look at the patient, there's no blister there. There's just what looks like a scar, and there's the epithelium that's kind of trying to regrow over the scarred area. And then you biopsy it, and it's got a blister like that. How can you tell that sort of fake phenomenon from a real blister?
I think
you said it before, but I want to just make sure you know what you were saying.
I guess the fact that it's like a full thickness separation and it's pretty uniform throughout.
It's even simpler than that. It's basically if there's something in the blister space, it's real.
Oh, so yeah, just that the fact that
if there are red cells in there, if there are any inflammatory cells in there, anything like that, it means if there's something in that space, it happened in vivo. It didn't happen in the technology, in the histo lab. It happened in the patient. So here you're right. You've got red cells in there. You've got some lymphocytes in there. So this is a real honest to goodness blister. And it happened in a patient with a relatively superficial perivascular infiltrate.
Yes,
sir. If you were going to look to see if there's vacuolar alteration here, you're going to have to look at the top of that blister, right? Because it's gone from here. You're going to have to look up here. So is there anything you see here that helps you?
So I am starting to see, I think the epidermis looks a little bit more pale. Maybe there is some lymphatic necrosis, liquefaction at the, or vacuolar changes at the base of as a basal layer.
Good.
I think there's potentially some necrotic cells as well.
Yeah, now I want you to hone in on that, because basically what you're looking at right here is a confluent necrotic epidermis. Everything's dead. This whole epidermis is gone city. I mean, it is a dead epidermis here. So this is kind of important. So you're going to see this on the exam for sure. And sometimes they might even just show you this, not even any of this stuff. They might just show you this. You're called to the intensive care unit, the burn unit at 2 o'clock in the morning. And they say, we want you to do a frozen section on this and tell us if the patient's got disease A versus disease B. Disease A, he needs IV fluids, he needs intensive care, he's going to die from fluid and electrolyte imbalance if we don't take care of that, and he might get sepsis. If it's disease B, we're going to put him on a different regimen and send him home tomorrow. So which disease gives you this pattern?
So disease A, this pattern, you would think something like Steven Johnson's.
Yes.
Let's say.
Yes. Good. Or erythema multiforme major or toxic epidermal necrolysis.
Yeah.
And I lump all those together.
Some type of
I
drug.
just lump them together. So I'm a lumper. Anytime I have a chance to lump, I lump. So I put these together as one disease. Now, some people will say that there tends to be less inflammation in TEN than in EM or, Steven Johnson, erythema multiforme major. Maybe there is. I've seen some cases of patients that had classic targetoid lesions, classic targets of erythema multiforme progressed to TEN over the course of my career. So that's why I lump. If I see somebody's got EM, I don't just say, hey, we're not going to, just forget about this. We're going to watch you because we don't know for sure what's going to happen over the next several days. You might turn into this. So I don't like EM. Sometimes it doesn't have a good outcome. But yeah, this is what you would classically see in TN. Now, what's the other disease that's classically the differential that the board might show you something and ask you to distinguish between here at 2 a.m.?
Would you think about something like fixed drug or?
Well, probably not if you're called to the intensive care unit and your patient's got widespread skin sloughing. That's not going to look like a fixed drug. But what's the other classic
like
disease? Yes, staph scalded skin. And there, the cleft is up here. It's in the granular cell layer. It's super high, so you're not ever going to see a confluent epidermal necrosis and staph scalded skin syndrome. That's basically an epidermolytic toxin that causes acantholysis up in this area. And so you'll see a subcorneal blister or maybe intracorneal intragranular cell layer blister in that area with some acantholytic cells. So frozen section of that, normal epidermis beneath that blister. Here you got confluent epidermal necrosis. And notice the basket weave cornified layer here. You see that?
Yeah, that tells us it's a very acute process.
Perfect.
Correct?
Perfect. Excellent. I like that answer. So this is going to be on your board examination somewhere. Okay. So you can thank me when they show this to you. You'll get the answer correct.
Thank you.
I will never miss this for sure. I'm going to get it right. Now, what they might ask you if you see this pattern is they may expect you to get that it's erythema multiforme, that kind of thing. And then they might ask you the difference between, say, MERM. The pediatric derm guys seem to love that. I was taught that mycoplasma was one cause of EM when I was in training. And so when they kind of split out MERM as a separate disease and this, that, and the other, I don't know. It doesn't really resonate so well with me. And I think there was a recent article in JAD a couple of months ago that talked about a lot of those MERM cases do have pretty severe disease sometimes. And it's not just something that's, they just get a few mucosal lesions and then it's related to mycoplasma. That sometimes they really can develop full-blown widespread Stevens-Johnson and EM. So I'm not so sure it deserves its own disease. I think a lot of other things that maybe deserve a better disease than that personally. Okay, this is a good case. This is a beautiful example of the pattern here. So this is just gorgeous.
All right, this is Michael from UT Houston. Are you guys able to hear me?
Yeah, perfectly.
Oh, okay. So here where you have a punch biopsy of what looks like a predominantly inflammatory process, kind of most striking is the amount of inflammations. We have both superficial and deep perivascular lymphocytic inflammation, and we also have profound perifollicular inflammation as well.
Good.
Kinda,
Very,
towards the
very good. Good observation. Excellent. Perfect. Is it
at
only
the-
around the follicles?
No, it's kind of everywhere, and there's also an interface, kind of lichenoid inflammation as well. Oh, and there's also a perieccrine inflammation as well.
Perfect. Excellent. And then you said there's also this pattern as well.
Yeah, so
Now,
with the
I want
lichen,
to call your attention to lichenoid. You know, I agree in many ways it is. It's band-like for sure, but does it actually obscure the dermal junction?
no, so I guess
Yeah,
it's
it
more
really doesn't.
interface.
Yeah, so if you're a purist, it's not really lichenoid. It's more of a band-like infiltrate, because if it's lichenoid, it really needs to obscure the basal cell layer. And you can see there's a nice there's almost like a little tiny grin zone here. So a lot of people get sloppy and they say lichenoid. Well, you know, it's not 100% lichenoid. So I agree, it's not. And notice it doesn't have any changes in the cornified layer here, really. There's no parakeratosis. There's no wedge-shaped hypergranulosis. So what disease is it? Probably not.
Probably not lichen planus.
Good. Excellent. It's probably not lichen planus. Good. But it
And
does
then
have a kind of an almost lichenoid band-like infiltrate. It's got a perifollicular, a perieccrine infiltrate. So what's the differential diagnosis here? This is pretty sophisticated level diagnosis here. I don't think they would just throw this on the board examination without giving you some pretty good multiple choice selections here.
Okay, so the main thing I was leading towards, and some of the other findings that made me think this, I do think we maybe have a little bit of a follicular plug overlying the hair follicle, and I felt like we also maybe had a little bit of an atrophic epidermis. So with this kind of pattern, I was thinking this could be like a variant of lupus, like a discoid lupus. So that's kind of number one on my differential.
But do you have any real effacement of the epidermal rete, and do you have any real vacuolar alteration or thickening of the basal membrane zone?
I thought there was kind of more peripherally, like right there. I thought that was like vacuolar change.
And I don't know. Some of that's probably just artifact. There might be a tiny bit of it, but do you really? And how about mucin? Did you see any mucin?
No, I did not see mucin.
You don't need mucin for lupus. Is that really a follicular plugging, or is that just a little sort of maybe parakeratosis adjacent? It's not even parakeratosis, it's a hyperkeratosis adjacent to follicle.
Mm-hmm.
I wouldn't say it's a bad thought, but it's missing some things. The epidermis really isn't thin, like that case of the Dagos, where it really was thin and really effaced and dead, which again, some people think Dagos is a variant of lupus. I mean, that's closer to lupus, that area that we saw. This has still got a very thick acanthotic epidermis over here. So that'd be kind of funny for discoid LE.
Another
Else
thought
can do
maybe.
So we put that in there. That could be lupus, but it'd have to be a weird case. And it's a little bit funny to get perieccrine inflammation of lupus. This is a tough diagnosis. So it's not, if you jump instantly this diagnosis, you're ready for a dermpath fellowship.
A couple other thoughts, on the differential folliculitis, but I think this is a lot too extreme for that. I think if we saw more spongiosis, we could think of like polymorphous light eruption, or maybe if we had more dermal edema.
But it doesn't really fit with any of those, does it? So whenever you get that kind of thing, you start scratching this, well, maybe this is something that I don't know. Maybe it's something that's out of my differential diagnostic armamentarium, or maybe I'm not thinking about it. So, and if the board were to show you this, they probably, because it's a hard diagnosis, they wouldn't just expect you to get it instantly just by looking at this pattern. Now, if you've been around like me for 30 years, whatever, if I see this, I instantly think of the diagnosis, but this isn't going to be one that you would think of necessarily. So they might say, well, this is a 25-year-old woman with a linear lesion extending from her mid-thigh down to her toe. And it's crusted in verrucous, and they might even show you a picture of it.
Okay,
Now
so the two things I would think of would be like one, lichen striatus, or maybe inflammatory linear Ilven verrucous.
Yeah, if you hear that clinical description. Okay, so those are the two things that you think about. Which of those would you choose? based on this histology. Which of those two entities has this histology with it?
I think I would go with lichen striatus.
You definitely would go with lichen striatus. Absolutely. And this is lichen striatus. This is a good example of it. It's actually, we called it blaschitis here, which is in the same family of that. But this is what lichen striatus looks like. This is the pattern of lichen striatus. It gives you this band-like infiltrate. It's not truly lichenoid like lichen planus. And it usually gives kind of a fairly normal, almost acanthodic epidermis of anything, because when you look at it clinically, it's somewhat crusty, somewhat verrucous. It feels like there's some texture to it. And then when you do the biopsy, you get especially perieccrine. That's the classic thing. When you see perieccrine inflammation, I want you to think, these band-like infiltrate, perieccrine, zoom, lichen striatus. That's the pattern I want you to think about in your brain. When you hear that pattern, like 3 o'clock in the morning, I give you a text, you answer, I say, okay, I just got a biopsy that shows a band-like infiltrate, lymphocytes, maybe a few extravasated erythrocytes, perieccrine. What do you think about? Lichen striatus, blaschitis. And if it's in a child, also, this is a pediatric young person's disease. It can give you perifollicular inflammation like you see here, but this is a classic pattern for blaschitis. And we don't have to go into a long differential diagnosis of other things that can give you this pattern. Mainly just want you to recognize this is what you see when you see a biopsy of lichen striatus. Other things that can give you this pattern, syphilis could do this. A drug eruption obviously can do it, maybe kind of a weird PMLE photodermatitis. I'd throw those in the differential. But if you hear that, and there's really no sun damage here, and it occurs in a young person, that kind of clinical description, this is what you should think about. And I think if they show this on the board examination, they probably would give you a clinical, because it is hard to just get this just purely on that basis. But the perieccrine inflammation is very helpful. So if there aren't too many things, just like there aren't too many things that give you papillodermal edema, there aren't too many things that give you perieccrine lymphocytic infiltrates like that. So when you think about that, think about blaschitis or lichen striatus. So that's good that you thought about that. Now, you mentioned ILVEN. Do you know what you see there?
So I feel like we would see features of like epidermal nevus, and then with a lot of inflammatory cells as well.
The thing about ILVEN, the way I would think about ILVEN almost as like linear porokeratosis with psoriasiform features. And instead of cornoid lamella, they get kind of a broad zone that's sharply cut off of perikeratosis. So it almost looks like focal psoriasis, if you will. It doesn't have the same, it's a different kind of basket. It's a different kind of cornified layer change in psoriasis. It doesn't have neutrophils in it. It's kind of a tiered perikeratosis, if you will, but it's focal perikeratosis with psoriasis hyperplasia, then areas that are just kind of normal looking kind of skin, and then another zone of it. So it's probably like multiple little somatic mutations, if you will. It's almost kind of like poro. So it doesn't, even though it's called ILVEN, it usually does have some inflammation there. It's not generally as inflammatory as this. It almost kind of looks like kind of little foci of psoriasis almost, if you will. It's an interesting histologic pattern. Okay, great. So that's some good stuff here. This is going to help you guys on the boards for sure.
Hi, this is Chelsea from UT. Can you hear me?
Yes, I can.
Oh, great. So for this one, I was thinking a neoplastic process.
Good. What kind of biopsy is this?
This looks like a very deep shave or an excision.
Yeah, this is an excisional biopsy.
So I think at first, kind of what draws my eye is this somewhat well demarcated nodular aggregate of cells in the papillary and reticular dermis. And it looks like,
at low power, you see this kind of dark looking thing. When you start looking around, is it really well circumscribed?
No, and that's kind of where I was going down when I went to higher power. That it's
so when you see an excisional biopsy in dermatology that's this big and it's neoplastic, you favor benign or malignant?
Malignant.
Yeah, just right off the bat. Boy, this doesn't look good. It's probably malignant. And then we ask ourselves, obviously, what kind of differentiation it's exhibiting.
So I thought, looking at the types of cells involved here, they looked spindled.
Good, spindle. So spindle Epithelial or non-epithelial?
I thought non-epithelial.
Good, perfect, exactly. You're just right down the fairway. That's exactly what we want. And so what are the major malignant spindle cell neoplasms that we're dealing with in dermatopathology? So the good news is for DermPath, especially for the DermPath boards, there's a relatively small number. The universe is small here.
So we'd think either something from maybe the smooth muscle etiologies or possibly a neural etiology if we're thinking non-epithelial.
Yeah, and then the third one is fibrohistiocytic. Those are the three most common ones that you're going to be facing in your dermatopathology board, part of the derm boards. There are others that can give you spindle cell lesions. You know, you can see spindle cell squamous cell, spindle cell melanoma. You can see spindle cell vascular lesions like Kaposi sarcoma and, you know, some variants of angiosarcomas, et cetera. But those are the major ones. So we're talking the main three are those. So of those three, which do you like here the best?
I think when I looked really closely at the cells, I favored that they looked kind of that cigar-shaped blunt ends. And then some of them I saw that at one end, that vacuole, that like glycogen snack that the books like to say. So I thought I was dealing with smooth muscle cells.
Glycogen snack. I hadn't heard of that one. That's good. Learn something new every day.
So I'm thinking we're in the smooth muscle category.
You're thinking right. And notice that you've got some mitotic figures here, very large pleomorphic cells. This thing is very, very poorly circumscribed. Now let's take a look out here. If we just looked at this field, what's this? Is this leiomyosarcoma?
It doesn't. I mean, I think because of what I know from the other part, maybe it is kind of fingers of it, but.
Or it may be that this is a benign component of it. And this is where it you know, kind of decided to go to the dark side. You know, it went over to instead of staying with Obi-Wan Kenobi, he decided to go over with Darth Vader, you know, so he degenerated into malignancy. And a lot of times that's what happens with these soft tissue neoplasms. They start off like bland little benign things, you know, and perfectly benign leiomyoma. It's just sitting there for years, not harming anything. And then it gets bigger and then gradually gets larger and maybe it ulcerates. And then somebody says, oh, this thing has changed. And then you take a biopsy and then lo and behold, it looks horrible over here. So this probably started off benign. And that's one of the lessons of soft tissue neoplasia is if you get one, you need to take a knife and fork biopsy. If you take a punch biopsy of like this area, well, guess what? You get little Bo Peep. Everything's fine. No cancer, nothing here. And you say, good, there's nothing to worry about. Meanwhile, evil is lurking over here. And this thing is possibly going to cause major harm to the patient and maybe even medical liability if you don't sample this area. So you have to make sure when you're dealing with a soft tissue neoplasm that you don't miss the nefarious area. Soft tissue neoplasms are often multiphasic, biphasic, triphasic. So you have to hit the right phase. And in order to hit the right phase, you sometimes have to take a pretty big biopsy. You can't just take a small piece of it and think you're going to necessarily hit this area. Sometimes the worst looking area is an area that's been traumatized and it doesn't really look that bad under the microscope. And sometimes it's deceptively bland, like a desmoplastic melanoma. If you biopsy that thing, it can look like a neurofibroma sometimes. Mm-hmm. So this is good. You're exactly right. So that's exactly the way to do this. You look at the morphology. There's some other subtle things about leiomyosarcoma. Talk about atypical leiomyomas where you get like maybe a few mitoses in it and it's not enough to call a sarcoma yet. That's more sophisticated. That's not a derm board type question. That's more of a real world type question that you need to know about. But you're exactly right. And if you wanted to stain this up, obviously you're going to do 3 main stains. What's the main stain for this one that you do?
Desmond?
You can do Desmond or mostly smooth muscle actin is the one that we kind of routinely do in derm. It's usually we're coming from smooth muscle origin. And then if it's obviously fibrohistiocytic, you're going to do things like CD10, which is the real good marker for atypical fibroxanthoma. Obviously, if you're worried about a neural neoplasm, you're going to do S100 protein or SOX10, one of those markers. So, and they're not going to ask you some of these bizarre stains. So don't get worried about that. Just make sure you know the most common ways to work up a soft tissue neoplasm like this that you might get on a board examination. So that's great. So you guys did fantastic. Nailed them, got them all right. So hopefully you learned a couple of things today, and we will do this another thing. Somebody asking some questions here in the herpes can be another cause of EM, and the answer to that is absolutely can be a cause of erythemal deformity. Okay, any questions about anything? We got through most all of them. We'll add that other one next time.
Thank you.
You're welcome. We'll see you guys next time.